let's start off with a poll just to kind of get everybody into it. So how often do you see IBD patients in your personal practice? So never, rarely, sometimes, or often. So I work in a multidisciplinary IBD center at Vanderbilt. We have over 15,000 IBD patients the last time we checked that came from over 27 states in the country. I'm very lucky that we have social workers and dietitians and psychologists kind of built into our clinic. So let's see. So how often do you all see IBD patients in your practice? Okay, great. So we have a little bit of a mix. Some nevers, a lot of sometimes. Well, your nevers are probably going to start seeing IBD patients soon because they are a lot of them. So, inflammatory bowel disease is an interplay of like 3 domains. It's a very complex disease. Patients often want to know why they have IBD. And so, they have to have the pre-existing genes that was passed down from your parents. You have to have an environmental change or trigger, and then the immune system changes with your gut microbiota. Neither factor itself is enough and sufficient for development of disease. And we know that there's an increasing incidence and emergence in previously low-risk populations, which really provides strong evidence to us that the environment for both Crohn's and UC is an important factor. It's important for you to know and recognize these risk factors and red flags when you see your IBD patients. There's a pre-course recorded talk that I did on the pathophys and treatment of IBD. If you haven't already, it's important for you to go back and review that so you can kind of figure out the difference between IBD and IBS and really be able to do a good job for your patients. There's a lot of signs and symptoms of uncontrolled inflammatory bowel disease that looks like infections, may look like other diseases, so it's important for you to be able to figure out what those are. Patients with IBD often lose weight or are unable to gain weight despite them trying. Fatigue is a huge problem in Crohn's disease and in ulcerative colitis, and a lot of times if you look at the studies, fatigue even outweighs patients' GI symptoms in patients with inflammatory bowel disease. Abdominal pain is common. Diarrhea, you can also see constipation. IBD doesn't just affect the gut, and so they have what we call extraintestinal manifestations, which are EIMs, and so joint pain, inflammation in your eyes, issues in your liver, and patients also can have low-grade fevers with uncontrolled disease. I want you to know there's a lot of high-risk features that you have to be aware of to make sure that your patients don't need to be seen in addition to a GI doctor and ones that need medication. So young age of diagnosis is always a risk factor. Extensive bowel involvement. So when you looked at the talk, so a Crohn's disease can be anywhere from your mouth all the way down to your rectum. Crohn's disease, ulcerative colitis has to start in your rectum and work its way up. Perianal Crohn's disease, stricturing, fistulizing Crohn's disease. These patients need to be taken care of in conjunction with your local gastroenterologist. And these high-risk features such as perianal Crohn's disease, stricturing and fistulizing disease, and upper GI tract disease all need medications, and you need to be able to encourage your patients and work with them to take medications in addition to working the functional medicine approach to care. There's not one test out there that will allow you to diagnose inflammatory bowel disease in your patient. It's a multitude of things. So you need the clinical picture. So you have to talk to your patient, see what's going on. You need lab work. You need endoscopy or colonoscopy with pathology and imaging. Often you need stool studies to rule out infection. Fecal calprotectin is also kind of helpful in this situation. You need all of these things together to help diagnose a patient with inflammatory bowel disease. The STRIDE recommendations are something that you might read about. So they're selecting therapeutic targets for us to treat in patients with IBD. Kind of think of it as a roadmap. So they used evidence-based and consensus-based recommendations for a treat-to-target approach in patients that have adult and children. So these targets are clinical response. So we want our patients to feel better, right? We need endoscopic and imaging improvement. So feeling better on the outside isn't enough. So a lot of times patients with inflammatory bowel disease can be tricky because they feel better on the outside, but that doesn't necessarily mean that the endoscopic inflammation is better or the small bowel inflammation is better. So persistent inflammation can lead to cancer, can lead to surgeries and fistula in these patients. So you really need to monitor them throughout their life. Once you've reached our targets, you're just not done there. You need to continue their therapy, and they need continued surveillance over time. So more than 2 million Europeans and 3 million people in the United States have inflammatory bowel disease. So those 6% of you that rarely or don't see IBD patients, they are coming. And there's been recent studies that show that there's a rapid emergence in Asia, especially in China, India, and the prevalence of IBD is expected to climb over the next few years. I always find that it's interesting to see the top-selling drugs in the country, and so these are the top-selling drugs projected in 2023, and 2 of these drugs, number 4 and number 9, are both used to treat Crohn's and ulcerative colitis. They also have more than one indication, but really I just wanted to kind of focus that the treatment of IBD is a multi-billion-dollar industry, but unfortunately these drugs do not work 100% of the time. They don't even really work 50% of the time. So this is where I believe that functional medicine can really help us get the rest of the way. We've been talking a lot through the weekend about the ATMs, so let's talk about ones that are specifically related to inflammatory bowel disease. Here you can see some environmental modifications that have been shown to be related to IBD disease activity. And there's been numerous studies published now that have been looked at examining the effect of environmental modifications on disease activity in IBD. And we know these environmental and lifestyle factors play an important role in the natural history of Crohn's and UC. Screening for depression and anxiety has become standard of care in traditional medicine. Smoking is a big one that they've looked at for a while. It's interesting, smoking is associated with more aggressive forms of Crohn's. Telling your patients with Crohn's to stop smoking is actually a treatment for Crohn's. If you have a smoker with Crohn's, they're more likely to require immunosuppression. Those patients need to go to surgery and don't do well after surgery. Interestingly, for ulcerative colitis, it has the opposite effect. Tobacco is protective for ulcerative colitis, and patients that have UC often do not have GI symptoms. No studies have really explained why there's that divergent effect between UC and Crohn's, but it's there. This study looks at early life factors, and these early life factors that kids are exposed to may actually exert the strongest influence on Crohn's disease risk and phenotype. So they found that breastfeeding was inversely associated with complicated disease, and maternal smoking during pregnancy was associated with increased risk of hospitalization. So showing really that early life factors can influence changes due to the microbiome and development of immunologic tolerance. The hygiene hypothesis was first formulated in 1989, talking about an inverse relationship between family size and atopic disorders. So this is a plausible mechanism for autoimmune diseases like inflammatory bowel disease, whereas this decreased microbial exposure in childhood may lead to development of IBD. So because of this, you want all your kids to go out there, and when they're eating dirt, don't get freaked out. You can just tell them to eat more. So when looking at your ATMs, you also want to look about medications that your patients are taking. What they have taken, what they're currently taking is very important. There's numerous medications not even listed on the slide, but ones that I want you to look out for are NSAIDs specifically. They've been known to trigger a flare or exacerbate symptoms. So up to a third of patients that are using NSAIDs with IBD have issues because of that. Estrogen has been proposed to modulate gut inflammation. Also, one that's not on there is iron. So a lot of patients take oral iron because patients with IBD are anemic, and oral iron can exacerbate GI symptoms and can trigger a flare in some patients. So patients with IBD have a complicated relationship with fiber. We've learned that soluble fiber, those coming from fruits and vegetables, is metabolized by our intestinal bacteria to short-chain fatty acids that inhibit these pro-inflammatory mediators. And we know that fiber helps maintain the integrity of the epithelial barrier, but patients with IBD have a hard time processing fiber, and so that's something that we'll talk about a little bit later. But in this one study, they found that women with long-term fiber intake had a 40% reduction in the risk of Crohn's. Also, dietary fat, looking at high intake of bad fats and low consumption of good fats have been associated to have increased risk for both ulcerative colitis and Crohn's disease. What about vitamin D? So vitamin D and IBD, the data suggests that vitamin D may have a role in the pathogenesis and course of IBD, but this is complex and the details are still a bit unclear, but they've seen that low levels of vitamin D, so levels less than 20, have been associated with an increased risk of Crohn's-related surgeries and hospitalizations. And if you take care of patients that have Crohn's or UC, you see that often patients across the board have low vitamin D. Zinc. Zinc has also been associated with poor clinical outcomes, so low zinc. In this one study, they saw that in Crohn's disease specifically, that it reduced intestinal permeability in a small study and reduced likelihood of relapse in patients that were using zinc. Also, in our patients that have a lot of diarrhea, high ostomy output, those patients are at increased risk of having zinc deficiency. Oh, it's fast. So flipped over that. So the enteric nervous system, we've seen this slide multiple times through the past day and a half, is, the stress induces changes in the gut. And this stress induces alterations in GI inflammation, as you can see here, modified by the HPA axis function. We know, and there's published studies, that stress can increase disease activity in IBD. Stress can also trigger a flare. There's also been data that shows that adverse life events, chronic stress, and depression can all increase flares even in patients that have quiescent IBD. So ultra-processed food is starting to gain traction in our standard medical care. In this study here, they found that patients that are people that were consuming 5 or more servings of ultra-processed food were at almost 2 times greater risk of developing IBD than those who consumed less than 1 serving per day. So they found there was a lower risk for Crohn's with higher consumption of unprocessed food, but surprisingly, they did not find this association with ulcerative colitis. So this was another study out of the UK that was just published this year, that they found that higher rates of ultra-processed food showed a higher incidence of Crohn's, but not for ulcerative colitis. And in people with pre-existing diagnosis of IBD, consumption of these ultra-processed foods were significantly higher compared to controls, and this was associated with an increased need for IBD-related surgeries. So ultra-processed foods is something that we really need to start focusing on our patients that have IBD or those at high risk for inflammatory bowel disease. So here's an example of a matrix of a patient with IBD. I'm not going to be able to go into detail on this just because of time constraints, but I think it was when I was going through this program, it was interesting. I wanted to know where everything kind of fit on the matrix. So you can kind of refer back to this when you're looking at your IBD patients or thinking about an IBD patient, like where you'd put everybody on this GI matrix. So let's move on to a polling question. So what do you feel are the risk factors for developing IBD? If you have more than one, make sure to put a dash. All right, smoking. So definitely. So remember, stopping smoking in patients that have Crohn's disease is a treatment. So that's something that really needs to be high on your list. Antibiotics, definitely changing the microbiome. Stress in active disease or in quiescent disease can increase GI symptoms or cause a flare. One that I haven't seen here, if people are thinking about race. So, whites have the highest risk of the disease, but it can happen and occur in any race. Genetics, so family history, right? So if you have one parent that has inflammatory bowel disease, they can have up to an 8% increased risk of their for passing it down to their child. If you have 2 parents that have inflammatory bowel disease, you can have up to a 30% risk of passing it down to your child. So that's why really focusing on your ATMs for these kids are important. Right, foods, ultra-processed food. Great. Don't you love a word cloud? All right, thanks. All right, so going through our 5 R's and working through the functional medicine approach, what are we going to think about or what are we going to do for our patients with IBD? So for IBD, our goal is to treat the underlying cause and cool down the inflammation using our 5R approach. So for more details on each individual R, I want you to refer back to previous talks on dysbiosis, food reactions, and intestinal permeability. So working through our 5 R's, a critical first step is that we need to remove the source of imbalance. So IBD patients innately have severe underlying dysbiosis from inflammation. So just at baseline. So in my personal opinion, I don't need a stool test to tell me that that's happening. So when you want to think about your remove, you want to focus on removing things that promote dysbiosis. You want to remove triggers. You want to look at each patient's diet individually. Are they being exposed to allergic foods? Are they doing things that are making them feel worse? You want to remove pathogenic organisms. Are there infections that aren't being treated? You also want to look closely at their over-the-counter and prescription medications and supplements, because things they can be taking could actually be causing them harm. So there are multiple potential mechanisms on how diet can affect the gut, resulting in the expression of IBD, which you can see here. Most likely, it's probably a combination of everything all together. And we're really just starting to understand how this is happening in patients with IBD. So again, patients with active IBD, even those that are at quiescent IBD, have impaired intestinal permeability at baseline from their intestinal inflammation. And we've seen different variations of this slide, but you can see how intestinal inflammation, in addition to everything else, all leads to inflammation and immune activation, and then systemic disease. And I think for IBD patients, we need another arrow that kind of drives it back around, because it's this perpetual cycle that they really just can't seem to stop. And though the exact mechanism or mechanisms responsible for the association between diet and the development of IBD are not clear, there are several mechanisms suggested. So you can see here like how unhealthy diets, such as our Western diet, can affect the gut microbiome in a negative way by triggering this pro-inflammatory environment, which causes this loss of immune function, loss of tolerance, and imbalance between your T helper cells and your Treg cells, whereas your Mediterranean diet kind of balances everything else and kind of pushes you away from that driving inflammatory process. We've learned a lot that how diet shapes the composition of our gut microbiota, and this plays a critical role in intestinal homeostasis. So this intestinal inflammation induced by gut dysbiosis affects us by the dietary nutrients by host cells and gut microbiota. I use this slide a lot in our patient education conferences so patients can really see how what they're eating can really kind of drive dysbiosis, and focusing on those things that activate your TLR4s and promote promote things that decrease gut inflammation are what you want to make the patients understand. So a dietary component previously overlooked in IBD are food additive emulsifiers. And so they're naturally occurring emulsifiers like lecithin in eggs, but the main research, what I'm talking about, is inflammatory effects of emulsifiers relating to food additive emulsifiers. I believe that IBD patients are extremely sensitive to these emulsifiers. And so when you think about these synthetic dietary emulsifiers, there's polysorbate P60 and P80, there's carboxymethylcellulose, and all of these can promote inflammation. This looking at the role of nutrients and food in the pathogenesis. So here's a cartoon of our epithelial barrier. And so you see how good diet, so beneficial nutrients and food, modulates the mucosal barrier immunity in a way and regulates our intestinal homeostasis. So we want to encourage patients to clean up, and we want to remove those things that are driving inflammation, which is the key number one place that I feel that you need to start in patients with IBD. So in summary, remove, there are multiple facets, right? Multiple layers in remove, and there's different ways to go about it. And you want to personalize your approach with each IBD patient is key. So moving on to our next R, we have replace. And so remember to refer back to 104, which talks a little bit more detail about the digestive insufficiencies. So we want to replace those things that are needed to help support the gut in patients with IBD. And I kind of circled focus on dietary and lifestyle factors because really that is one thing that you can do to help replace patients what they need in addition to nutrients and supporting digestion and replacing things. So back in the 90s, you can see here in this chart, there was very limited data on diet and IBD. And I was taught back when I was a fellow when I was a resident that food did not impact the disease. And I saw in many clinic visits where the gastroenterologist was like, it doesn't matter what you eat. There's nothing that you can do to eat or not eat to make your disease better. And we're starting to learn that this is the exact opposite. Thankfully, as you can see, the body of literature has been slowly increasing over time. And I think this is going to continue to grow as we just now have the understanding that diet and nutrition have to be a part in the care of an IBD patient. So recent advances in our basic and clinical science over the past year have dramatically altered our appreciation for diet and our role in IBD. Thankfully, in my clinic, we have 2 dietitians that help us take care of IBD patients, but a lot of gastroenterologists, I would say most gastroenterologists, really don't have the luxury of that. So I think that's a good place where us as functional medicine providers can step in. Liz Lipsky gave an excellent talk earlier, and I would refer back to her Friday morning talk and pre-course material talking about the individual diets, because I can't even come close to explaining the diets as well as she can, because she is an amazing teacher. In the clinical care of the IBD patient, we use a treat-to-target approach, just like I showed earlier, like the target, the STRIDE recommendations. And so you can think about diet as the same way as we think about medical care for patients with Crohn's and UC. So there's different targets that you want to reach when you're using dietary therapy. So goals of dietary therapy for IBD could be first to induce remission, maintain remission, prevent a loss of response, avoid complications and surgery. This often has to be done as an adjunct to traditional IBD care in patients that have moderate to severe disease. It's important for you as functional medicine providers for patients to understand that. There's a huge spectrum of disease with inflammatory bowel disease, and so patients with mild disease are nothing like patients with severe perianal pan-GI tract Crohn's disease. So often these moderate to severe patients need to be on medications, and it's important for us to understand that. So diet is powerful, but you need to personalize your plan and be mindful of your patient's overall inflammatory burden. We've found that we know that excessive consumption of sugar, animal fats are considered a risk factor for IBD, whereas our high fiber diets and citric fruit consumption can play a protective role. I want to mention that it's important to remember that even though fiber is great, it can cause a lot of symptoms in patients that have active IBD. I have a lot of patients that come into clinic and they're like, I don't understand why I feel bad. I'm eating salads 3 times a day. I'm eating all these fruits and vegetables, and because they think they're helping themselves. But in patients that have active disease, fiber needs to be low. So you need to get their fiber down low, get them in remission, and then slowly increase their fiber intake over time. I want to talk a little bit about a FODMAP diet because there has been some studies looking at IBD with a FODMAP diet, and we have talked about FODMAP with our IBS patients. So up to 40% of IBD patients have overlapping IBS. And so FODMAP can be helpful for these patients that have these IBS type symptoms or have concomitant IBS with their IBD. But low FODMAP is not that helpful in the underlying inflammation of IBD. So Dr. Lipsky went over a multitude of diets that you can consider in patients with IBD, but the recurring themes that I like to pull out and talk to patients about are, omega-3 fatty acids and increasing your omega-3 to omega-6 ratios are increased with decreased risk. We talked about the dietary fiber. So when they're in active flares, you want your fiber low. And then when they're in remission, you slowly want to increase your fiber over time. So diet rich in fruits, vegetables, and fish are associated with a decreased risk of but not UC, surprisingly. Vitamin D is associated with decreasing risk of both Crohn's and UC. So again, that vitamin D theme coming where we really need to optimize that. Both dietary iron and alcohol have no association with Crohn's and UC, but both oral iron and some things are high in oral iron and some alcohol can be triggered for patients. Dietary polyphenols are also kind of coming up to play, and we know that polyphenols are involved because of the oxidative stress. So oxidative stress can be a mechanism in the etiology of IBD and a driver of persisting inflammations. So we know that dietary polyphenols have an antioxidant and anti-inflammatory properties. And so there's limited studies, but there was one prospective study, and they found that there was a reduced risk of Crohn's in patients that had a higher intake of flavonoids and resveratrol. So these polyphenols may help prevent inflammation through inhibition of biological processes related to this oxidative stress. And they did look at red wine. And so, our GI mucosa is constantly being exposed to these like pro-inflammatory oxidants. And they found that red wine consumption was associated with increased greater alpha diversity in the gut microbiome. So all of you that were chatting about wine earlier, there's a reason for you can drink some red wine. But what about us white wine drinkers out there? Unfortunately, not as good data. So I'm not encouraging us to tell our patients, IBD patients, to go out to drink. I do often get a lot of questions about alcohol, so I think it was something that interesting to talk about. But you also need to remember alcohol during an active flare or alcohol for any IBD patients sometimes can be triggering. So that's a conversation that you might want to have with your patients. In the toolkit, there are a whole list of polyphenols, and I use that to go through that with my patients to see what they're eating and what they're not eating. We need more large prospective cohort studies to measure polyphenol intake, but increasing the dietary intake in your patients with IBD, addressing these micro and macronutrients are important during your assessment and your treatment plan. Another question I get a lot with all these new kind of fad diets is about red meat. So there's not a lot of data out there looking about red meat and processed meat with IBD, but there is this one study that was shown here, and they found that the amount of red meat or processed meat was not associated with time to symptomatic relapse in patients with Crohn's. So insufficient evidence out there to recommend reduction of red and processed meat consumption solely for improving Crohn's outcomes. But again, every patient is different, and so you need to see if it's something that could be causing an issue. Liz Lipsky talked about this CDED and IBD diet, and so CDED is the Crohn's disease exclusion diet, and they use this in supplement with parenteral enteral nutrition, and this was a protocol that was developed in Israel. These are the foods that they specifically removed during the CDED diet, and they added this. It's a little bit more complicated than that. You can see the reference down below, but it wasn't as simple as just a typical exclusion diet. So they used the exclusive enteral nutrition. And so for those of you that don't know what that is, they're only allowed to use this enteral nutrition and nothing else. So they can't eat anything else. They can't drink anything else other than water. And so this is something that we do use in kids because we know that it can induce remission for moderate to severe Crohn's, but it's really tough to do and it's very hard to maintain. But when you look at the study overall, they found that the CDED plus partial enteral nutrition was better tolerated than exclusive enteral nutrition, which seems like common sense because people want to eat. They're going to do much better than those that weren't allowed to eat at all. Most recently, in the adult version of this diet, this was also published using their CDED diet with or without partial enteral nutrition. And it was effective, both of these ways were effective for inducing and maintaining in Crohn's patients. Again, in my experience in the US here, most adults don't tolerate enteral nutrition diets. So again, exclusive enteral nutrition consists of completely using a liquid formula diet while avoiding all other forms of oral intake. And so there have been studies that shown that this is superior to oral steroids for induction of remission in children, and there's really no side effects, and it is recommended as first-line treatment for Crohn's. But again, this exclusive enteral nutrition requires a firm commitment from the parents and from the kids, often because it tastes so bad, they have to put an NG tube down their nose into their stomach and feed them every day, which kids tolerate pretty well, surprisingly, but as adults, as you can imagine, they're not going to tolerate this. So this really isn't a viable option for patients with Crohn's, but it does work. So when you think about dietary considerations for Crohn's and UC, you want to optimize all of your nutritional parameters, and that's important in your treatment plan and also during your assessment. I want to mention the most recent meta-analysis that was published last year. They looked at 27 studies. And really the takeaway from this was that it's really hard to measure in the literature and it's kind of imprecise. But what I want you to take away from this is that there's not a one-size-fits-all diet for IBD. You really have to work with each patient individually, and that's what's important. So patient personalization, and I think utilizing our timeline and our matrix are our best resources to improve our overall quality of life. So we know that diet plays a role by modulating our microbiome. But diet alone as an approach to therapy is an alternative attractive, but we need to explore further. But personally, I think optimizing your IBD patient's diet as adjunct care, traditional medical treatment is key for every IBD patient. So remember, monitor and correct your nutritional deficiencies. In regards to diet for my patients, unless they're really willing to do the work and very dedicated, I think overall the Mediterranean style diet is the best one to recommend, and just talk about a whole food diet. I tell my patients, if your food is shaped like the container, you should not be eating that. You can use exclusive enteral nutrition, but like I talked about, it's very difficult. And diet may have a role in primary therapy for mild disease, as long as there's careful monitoring of your disease and you need to continue to monitor their nutritional status.
Dr. Bolio, thank you so much. A couple of questions. First, I'll just say it's so refreshing to have a gastroenterologist talk about diet and IBD. As you said, that when you were training, you didn't get so much of that.
Yeah, we didn't talk about that at all. But surprisingly, they're coming. I mean, everybody's on board now. So again, like I said, like most gastroenterologists don't have dietitians. They don't have access to dietitians. They don't even know the first thing about it, really. So I do a lot of lectures on trying to teach people and other GI doctors. So I really do feel like that's where our functional medicine providers can help support us gastroenterologists by bringing in that component to IBD care.
That's great. So obviously you talked about a continuum of patients in terms of what they're willing to do and putting them on a continuum and,
to be able to do
personalizing.
It's hard work.
Absolutely.
I mean, some of it's hard.
So a couple of questions that came up. First, have you, in your clinical practice, used the specific carbohydrate diet incorporated or had patients and nutritionists use that, and what's your experience with it?
Yes, so I do, for patients that either aren't responding to medications or wanting to avoid medications, we do talk about the specific carbohydrate diet. I do believe it works for mild to moderate ulcerative colitis and mild to moderate Crohn's disease. Any of you that know a lot about the SCD diet, it's not easy and it's hard. Yeah. So patients have to be willing to do it, and you pretty much have to do it forever. The patients that I have had to do it, when they try to kind of like expand their diet, they just start getting sick again. Mm-hmm. So it really is, and the 2 patients that I have on it, or 3 now, I think, it is pretty much a lifelong commitment. So they have to be very mindful of the food that they're eating, make sure that they're getting adequate nutrition. I don't want anybody to do the SCD diet without working with my dietitian, because it's so easy for them to get more macro and micronutrient deficiencies because they're eliminating all these foods. So I do think it does work. For the right patient, but they have to be motivated, and you need to do it in conjunction with a dietitian or a provider that's very knowledgeable about it.
Speaking of adequate nutrition, and you talked about iron and the problems with supplemental iron and exacerbations. Do you have anemia with IBD? So what do you do in that situation? Are there particularly have them talk to the nutritionist about foods, or what's the strategy there?
Right, so it kind of depends on their degree of iron deficiency anemia. So with patients that have moderate to severe IBD, you'd be surprised how many gastroenterologists don't check their iron in their iron panel, and so they come to me and no one's ever checked it, and their iron is like 3 and their ferritin's like 10. So those patients need IV iron, right? Like you're not gonna you gotta fill up the tank. So I'm a big proponent of IV iron, because if we can tank them back up and then maintain with nutrition, that's the best way to go. For patients that have borderline iron deficiency and really aren't that anemic, yes, working with the dietitian, increasing their iron-rich foods, increasing their snacks with iron-rich foods, to really educating them what has iron in it and what they should be eating, I think is very helpful. Some patients can tolerate oral iron, and so those that want to be on oral iron and need to be on oral iron, there are some out there that patients can tolerate. I tell them to start at low doses, but if they have any kind of GI symptoms whatsoever, stop.
Any particular oral irons in terms of glycinate or particular chelates, or it's just a trial and error?
This kind of trial and error. There's a new one out right now, but it's not very well covered by insurance. Again, it becomes like an insurance issue. IV iron usually can always get approved by your IBD patients. They never not approve it. And so that's typically the way that I go, is to tank them up with the IV iron and really promote the nutrition to maintain that iron and treat their underlying inflammation, which will keep them from getting anemic again.
I got you. And one last question. You talked about emulsifiers, which is they're in a lot of things. So do you, or just, as she's also said, that if their food looks like a package or
just like the wrapper.
So do you just tell them stay on a whole foods diet, don't have any kind of processed foods at all, to stay away from those? How do you frame that?
I do feel like that IBD patients are super sensitive to processed food, fast food, but because of the disease itself, they're kind of drawn to these low fiber processed foods because that's what their GI tract can break down, right? So they realize like if they eat these certain foods, they're not going to have diarrhea. If they eat a salad, they go to they're stuck in the bathroom for the next hour. So they kind of get focused. They just go towards these foods. So really trying to get them to get away from the fast food, away from the processed food, and just starting with the whole food diet is really what I do. I just baby steps.
Okay, I'll be back.
Okay, good to see you. Let's move on to our third R, which we have reinoculate. Remember, there's that 105 dysbiosis presentation, which was amazing to refer back to. So when we think about reinoculate, there are a few interventions that kind of come to mind. And using these interventions may be beneficial for IBD patients, but like the type of what we're going to use, this number of strains, the dosage, the intervention schedule, all of these seem to be unclear and a little bit controversial in traditional medicine. As you can see here, the jobs of our intestinal microbiome are vast. It does so much. And there's these complex interactions that are dynamic between immune, hormonal, and neural pathways. So really trying to figure out ways to optimize this is key in our functional medicine approach to care. I like this slide here because I used to get confused, like what was all the differences between pre, pro, post. So as you know, like probiotics that we've talked about a lot alter our bacterial diversity, while antibiotics decrease our bacterial diversity. You know, fecal microbiota transplant, or FMT, is the ultimate way to increase bacterial diversity by altering the gut microbiome. But remember, this isn't without risks. And fecal microbiota transplants are only approved for patients with severe recurrent C. diff. So you see here that prebiotics and probiotics form symbiotics. So prebiotics are our substrates that are utilized by the host microorganisms that confer a health benefit. Like we learned that prebiotics are characterized as polyols, so like our sugar alcohols, oligosaccharides, soluble fiber, which can be found in our good foods. And then postbiotics are byproducts of our probiotics. So there's a lot of good handouts in your toolkit about prebiotics. I want to recommend that we start slow in our IBD patients. Like I said, fiber can be very difficult for them. So introducing one or more prebiotic foods to a patient's current nutrition plan is what I try to do to try to help feed that beneficial gut microbes. And it may even be less than one, even half of a one. So, but refer back to your toolkit because you can see that probiotics are found in over 36,000 products of plant origin. If you're a data person and you really like to do deep dives into all of the data out there, I kind of put this slide for you to refer back to. This is all the published data that we have in prebiotics and IBD. As you can see, it's pretty old data, like 90s, early 2000s, but not a lot out there, nothing that we've had recently. In everyday people, including ourselves, the modern lifestyle which we live, it's really difficult for us to maintain a healthy gut flora due to stress, hygiene, antibiotic use, medications. All of this causes dysbiosis. So think about how hard it is for an IBD patient. So all of this is kind of amplified in patients with IBD. And so thinking about what probiotics do, listed here, so many things, they can really do some amazing things, but we don't really know, again, which strain, how much, how many, how long. So still a lot of questions to be unanswered. if you look at all the different studies looking at probiotics and IBD, you can see them listed here. Again, newer studies compared to the prebiotics, but a little bit mixed in regards to the results. These are very small studies. You can see the number of patients that were involved and the durations are short, which I think probably has a lot to play. So there's numerous brands, as we know, and as you know, of probiotics out there, and it's even confusing for me, which ones are best for our patients. There was one study that most gastroenterologists know, so I want you to know it too, looking at the probiotic VSL number 3. So this was a meta-analysis that was back from 2017, so a little old. But what they did show that this probiotic was just as effective as 5-ASAs, so those are anti-inflammatories for our colon, and preventing relapse and quiescent UC. So VSL is now under a new trade name called Visbiome. Using this in our Crohn's patients, a little bit uncertain, but from an academic standpoint, we need more randomized controlled trials before their utility is really known. Our symbiotics, so those are our combined probiotics and our prebiotics. So there's very little data on symbiotics and inflammatory bowel disease. The ones that I found, you can see listed here. But I think the theory of combining probiotics and prebiotics is really a promising novel approach. But again, few studies published. The most frequent symbiotic formulas that I've seen was the lactobacillus and bifidobacteria with a fructooligosaccharides and our inulin. Again, if you want to do a deep dive, all the data is listed there. So we know that we've learned postbiotics are found in our fermented foods, our kefir, our kimchi. I'm super excited about our cooking tomorrow. And we've learned throughout the conference, I think a common theme that I hear among everyone is that personalized nutrition interventions are the cornerstone of functional medicine care. And I think this is even more important in an IBD patient because, again, the spectrum of an IBD patient from mild to severe, the amount of inflammation they have is very vast. And so for probiotics, sometimes you can actually make your IBD patients feel worse. So you need to be aware of that when determining treatment regimens. So this idea of postbiotics may represent a more valid and safer alternative than actually probiotics in immunocompromised patients like IBD patients on biologics. So when our bodies or our bacteria consume the probiotics, we increase our short-chain fatty acid concentrations in the intestine. So that's how, by increasing our probiotics in our IBD patients downstream, we're improving or increasing the short-chain fatty acid concentrations in the intestine. Here you can see all the different roles that short-chain fatty acids do. They improve your mucosal barrier function. They increase intestinal mucus synthesis. They stimulate production of these Treg cells and immunosuppressive cytokines, reducing our pro-inflammatory mediators. So all of this can help our patients with IBD. Looking at the 3 individual short-chain fatty acids are here. Given the time that we have together, we can't really go through all this, but I thought it was really interesting to see what is the mechanism of action of each of these short-chain fatty acids and a little bit of the data out there that has been published. Looking at all the short-chain fatty acid enema or short-chain fatty acid treatments in patients with IBD, you can see listed here, again, going from 1997 all the way up to 2010 is like the most recent, so really not studied. In theory, when you look at all of the great things short-chain fatty acids do, you would think that the enemas should help patients with IBD, but unfortunately the data published so far does not support that. Probiotics can be dangerous for some people. So those with severe immunocompromised state like cancer, sepsis, premature babies, we don't use probiotics in that patient population. And so paraprobiotics is something that's, the term was first used in 2011, but it's not something that I even really heard about until recently. They've been shown to modulate anti-inflammatory and positive immune response, but I can't find any published studies of using paraprobiotics in IBD patients. I wanted to mention it to you so you could be familiar with the term, but there's no data in IBD patients, and all the data that I could find were more kind of like in vitro studies. So in conclusion, prebiotics in data has not yet shown to have positive effects, but there are no harm. I do think it's important for us to stress in our IBD patients. Probiotics, there's some data that says it's great. There's some data that says it does nothing. In the data that you look, it's more beneficial in patients with ulcerative colitis over Crohn's disease. And then you see a benefit of a multi-strain approach over a single strain approach. Symbiotics data is inconclusive. Paraprobiotics, I don't know much about it. Postbiotics studies aren't standardized, inconsistent results. Again, we know there's beneficial effects of short-chain fatty acids, so I think kind of starting at the top with our prebiotics is something that you need to focus. Lastly, FMT, I can kind of consider that the ultimate uber probiotic. A lot of patients come to me asking for a fecal transplant, but you need to remember that fecal transplants in IBD patients is not approved by the FDA. You cannot legally do a fecal transplant outside the scope of a clinical trial. If you do it, it needs to get the approval of an IND from the FDA. So of the studies that have been shown, a fecal transplant has been shown to be a viable option for patients with IBD, specifically ulcerative colitis. So I think this is definitely going to come at some point, but right now we're still trying to figure out the best strategy, best administration route, best donor, by using a fecal transplant in IBD. So overall, remember, every IBD patient you have is different, given this huge spectrum of the disease itself and given the huge spectrum of us as humans. So you really need to personalize your intervention. That's key. So what about repair? So repair, we got a lot of things that we have in our toolkit that we can use repair, in addition to the nutrition changes that will also repair someone's gut. So when you think of repair, I think of like anti-inflammatories, of herbs, spices, nutraceuticals, and botanicals. So this is a slide that I remembered looking at when I was doing my modules, which now gives me a little bit of PTSD looking at, because I did kind of, I think I did laminate it and I studied from it for a long time, but it's a great summary slide for clinical practice. And when you're if you want to take the certification test, looking back to study for the certification test, you can kind of see where all the botanicals are in the cascade and how you're blocking inflammation. So optimizing vitamin D levels in our IBD patients, I always tell my residents and fellows, like, this is low-hanging fruit for your IBD patient. This is something easy to evaluate for and something easy to fix. So vitamin D influences so many things. In addition to bone homeostasis, it actually is a potent immune regulatory function in our body. And so there's been a lot of data out there looking at vitamin D, and there's been several studies, mostly in MS, diabetes, and Crohn's disease. So here in this study here, in the slide, you can see that the relapse rate was lower among patients treated with vitamin D3 among patients treated with placebo. So again, really check your patient's vitamin D. Your optimal blood level for immune support is between 50 and 80. Getting an IBD patient to 50 sometimes is just even as hard as is really hard. So that's pretty much just getting it at that low level of 50 is what I shoot for. You typically don't want to go over 100. It's definitely not harmful, but you can get toxicity. And I have seen GI symptoms for patients who run their vitamin D super high. So you want to be mindful of that. So remember that, optimizing their vitamin D helps balance their immune response. And this decreases that pro-inflammatory condition that we see in our patients with IBD. In the toolkit, you can see a lot, that there's 6 pages in your document found in the IFM toolkit that looks at associations and considerations for us looking at vitamin D. So what about L-glutamine? So evidence suggests that L-glutamine can have antioxidant, anti-apoptotic, and anti-inflammatory activity in IBD. So glutamine is considered an essential amino acid because its consumption increases during conditions of catabolic stress, including trauma, sepsis, post-surgery recovery. So glutamine is the most important fuel for enterocytes, so that's our small bowel cells and immune cells. So glutamine is the main metabolic fuel source. My clicker doesn't like me anymore. So there has been some studies looking at oral and rectal supplementation of glutamine and how it affects the intestinal inflammation. This was a study specifically in patients with ulcerative colitis using 30 grams of glutamine daily for 4 weeks. So although glutamine supplementation in theory has been shown to be beneficial in murine models, so in mouse models and experimental colitis, the utility of amino acids like glutamine and IBD still kind of remains poorly understood. In this short study, they used glutamine at 30 grams a day for patients with UC, but as soon as they stopped it, the disease returned, the inflammation kind of revved back up again after the treatment was continued. There are other clinical studies out there that use glutamine supplemented enteral nutrition and also glutamine supplementing in TPN. And when you look specifically for Crohn's patients, like pediatric Crohn's and adult UC patients, it didn't improve their therapeutic outcomes. So we definitely need more studies to kind of get us to understand how we can use this in our patients with IBD. Here's a good list of the different bioflavonoids and their dosages. I use this again a lot to kind of refer back to kind of give me a general guideline of where I'm going to shoot for my patients with IBD. You're definitely not going to start them on everything, right? Like you're not going to pick everything on this list and just throw the kitchen sink at them. I kind of try to be a little bit more mindful of this by trying to increase things in their nutrition, also being mindful of their supplements. I work at an IBD center and we work on a purely insurance model, so supplements can be very expensive for my patients and they can't afford it. So trying to find ways to get these botanicals in their diet can also be helpful. This is another great slide to refer to during studying, talking about the different botanicals, what are the indications, and the dosages. So if you look out there, patients with IBD they're the highest users of complementary and alternative medicine of all patient populations. If you look at the studies, it's anywhere from 20 to 60% of patients with IBD go out and search some kind of complementary medicine. And their primary motivation is for this, when you look at them at surveys, is because they're concerned about side effects from traditional IBD medicines and also the fact that the IBD medicines really don't work all the time. Like I said, up to 40% at best case scenario. So unfortunately, there's not a lot of data out there looking at complementary and alternative medicine, like integrative therapies with IBD. This was one that looked at a systematic review of all the publications out there. For herbal medicine, there was only 26 randomized controlled trials, 7 randomized controlled trials for mind body, and 2 for acupuncture. When they looked at all that together, they found the best evidence was found in herbal therapy with curcumin and wormwood and Crohn's, mind body therapy and self-intervention for UC, and acupuncture in UC and Crohn's disease. So what about worms? This was something that a couple years ago was pretty popular, and people would ask me about worms. It's kind of fallen out a little bit of favor. So why worms? So there are some epidemiologic studies that looked at helminths, so worms, in childhood. So children exposed to worms were protected against development of IBD later in years. And then they tried this in animal models in IBD, and they found that helminths were showing protective effects and changed the bacterial flora in the gut. And so when they used this in an IBD model, it likely downregulated the Th1 intestinal inflammatory process, like you can see here. And so the idea behind this is downregulating this intestinal inflammation with the helminths. And there was actually a clinical trial that I was part of, probably it's like 5 or 6 years ago, looking at a specific worm called the Trichoceros suis ovis, or TSO therapy, and it attracted a lot of attention. We were very excited about it, but the clinical trial closed because there was no benefit to the therapy when they looked at the data. But there is a lot of evidence that these helminth infections can cause a variety of health problems and can even be fatal. You can see worms can give you severe anemia, they cause GI bleeds, they can cause obstructions, pancreatitis, vision loss. There is even one case report where someone used worms and that went to their brain. So do not give your patient worms. That's the overall theme right there. But what you can think about is low-dose naltrexone. So low-dose naltrexone has been used to treat autoimmune diseases in the U.S. since 1985. There's very few clinical trials in general, with the most of the studies published being with multiple sclerosis. So we know this medication, this low-dose naltrexone, can increase levels of endogenous opioid peptides and promote healing. It inhibits cell growth and reduces inflammation. It blocks these inflammatory cytokines like IL-12 and TNF-alpha, which are what we block with our biologic medication, and it kind of shifts your immune response. So after you decide to start LDN, if you choose to use LDN in your patients, usually you should see some kind of change around 6 weeks, but you definitely want to give it a full 12 weeks before you give up on it. In my personal experience, I think you need to start low and titrate up. Typically, my starting dose is about 0.5 milligrams, and my upper level of dose is 4.5. I dose it once a day at night. You can try BID dosing for mood and pain, and the most common side effects I'll show you in a slide or two. It can cause GI disturbances. I do have a couple patients who have felt worse on LDN, so that's also a possibility. Published data is limited with LDN and IBD. The studies that are out there didn't show any kind of improvement in Crohn's, but it is a safe medication, and it's potentially beneficial as adjunct to IBD treatment to what you're already doing. So if you want to think about looking at the mechanism of action, so the LDN docks on these mu receptors, like you can see here, but only for a few hours. This blocks your opioid growth factor from docking. And so the LDN is displacing these endorphins from the opioid receptors. And when it does that, it causes improved modulation of the immune system. So in theory, this actually can help patients with IBD. There they go. So what are the side effects? So LDN is typically pretty well tolerated. The ones that I've seen in my experience is it can cause some vivid dreams and changes in people's sleep. I've also seen it increase GI effects. But here you can kind of see all the potential side effects with LDN. But again, it's pretty well tolerated. The risks are low, so it's something that you may want to consider using in your patients with IBD. So what about cannabis? Here you can see the indications of medical marijuana that vary state by state. So our blue are legal for recreation. The green, you can see, is legal for medical use. The gray is illegal. As you can see, I'm Tennessee. It's very illegal. And the D in the green is decriminalized. So we have these endocannabinoid systems throughout our body, right? The main receptors are our CB1 and CB2 that you can see here. So CB1 and CB2 decrease motility, they can decrease inflammation, and they can decrease immune activation. So in theory, this potentially could be a treatment for autoimmune diseases, specifically IBD. One thing that I want you to be aware of is the cannabis hyperemesis syndrome. This is something that you can see a lot and can be confused with active IBD or other disease states. So you'll see someone, their symptoms mimic a lot cyclic vomiting syndrome. So that's what CVS is. So patients have severe vomiting. This presents after prolonged excessive use. This isn't like a one-time use. These are the patients that are using it every day. One of the questions that you can ask them to kind of differentiate this cannabis hyperemesis syndrome is a lot of times just ask them if they go into the shower and does a hot shower make them feel better, and does a hot bath make them feel better. Often if they have this, they'll tell you yes, and that's a clue. So, and the only thing that you can do is get them to stop the cannabis, and the symptoms will go away. In the use of cannabis for IBD patients, the pros are it does really help patients' symptoms, right? It can decrease diarrhea, it can decrease abdominal pain. A lot of patients feel that their nausea is better, their joint pain is better, and they have increased appetite, so they eat more. But in general, it does not induce remission in IBD. So you're not really getting to the root cause, which is what we're trying. We're just kind of masking the underlying symptoms of inflammatory bowel disease. So it's giving people a false sense of security that they're better, but they're really not better. You're really just treating the symptoms. If you look at the data of cannabis use in IBD patients that continue to use it over time for treatment, a lot of times it leads to discontinuation of medical therapy because they stop their basic medications because that they think the cannabis is working. And also there's one paper that shows that it can increase risk for Crohn's disease surgeries. I don't think that's because of the cannabis itself, but if you're not treating your disease, you're going to end up needing surgery because your Crohn's is just going to continue to fester over time. So Ching dye, what's also called indigo naturalis, is not a new compound. It's been around for a while. And you can see it's used traditionally for fever, swelling, and topical infections. There was a study in 2016 that used this Ching dye, and they were actually able to induce remission in patients that had ulcerative colitis. The problem was it caused significant liver dysfunction with high liver function changes in a lot of patients. So this is not something that you're going to want to use with your patients with IBD. But this year, or actually I think it was last year, I learned about this new proprietary blend that's out there where they use a little bit of Ching dye in combination with a gut-directed curcumin for patients with inflammatory bowel disease. And the formulation that they developed, which came out of Israel, targets and releases this right into the gut. So the indications for using this proprietary blend is patients that have ulcerative colitis or Crohn's colitis. Since it does have that Ching dye in that, or the indigo blue, anyone that has liver disease, so primary sclerosing cholangitis, autoimmune hepatitis, any kind of liver dysfunction, this is not what you want to use for patients. It hasn't been tested in pregnancy or breastfeeding, so you do not want to use this in a patient who's pregnant or going to get pregnant. There is a risk of increasing your hypercoagulable state, so increasing your risk for blood clot. So if someone who has an underlying hypercoagulable state, you do not want to use this supplement. Pulmonary arterial hypertension and significant cardiovascular disease, these are not patients you want to put on this. When you look at their data that's been published, they found that you can increase your LFTs because of this Ching dye component, and you can worsen headaches, and some patients can have worsening diarrhea. Because of this effect on your liver functions, if you choose to start this supplement, remember you want to do a CBC and CNP prior to start. And then again, I recommend checking it again in 4 to 6 weeks. When I start patients on supplements or some kind of supplement protocol, specifically this one, I like to check their fecal calprotectin before I start. And with this one, I check it in 6 weeks because I don't want them to continue on something that's not working. So I think this is a very good non-invasive test to see if what you're doing is actually changing things at a gut level. This supplement, if you go online, they actually have a survey that helps guide the patients to what protocol they need to do. And the more severe the disease, the higher the proportion of Ching dye is in the whole capsule. And you can kind of see here, once they get into remission, all it is concentrated curcumin, and there's no more Ching dye. Of their published studies, these are 2 that I pulled out. And so this is using this proprietary blend. You can see on the left-hand side, so this was a woman with active ulcerative colitis. She was on a 5-ASA, so she was on that oral anti-inflammatory, and she was getting ready to start vedolizumab, which is one of our biologic medications. And while they were waiting for approval, they put her on Curcuti. And you can see on the top, her colon is really friable. You can't see these mucosal vessels. There's a lot of mucus. There's a lot of inflammation. And down at the bottom, you can see there's overall improvement by using the supplement. Again, on the right-hand side is a 24-year male with ulcerative colitis who's also on biologics and an immunomodulator. Infections were negative. So pretty much was almost to the end of the line here, and they added this supplement on there, and it's quite impressive how it can, affect severe inflammation. So this is something that you might want to consider using in your patients with ulcerative colitis or Crohn's colitis. So in summary, there's a lot of different ways that we can use anti-inflammatory herbs, spices, nutraceuticals, and botanicals. There are a few that are listed here. I think the emerging therapies like using low-dose naltrexone and this proprietary blend for UC and Crohn's colitis is really exciting. And then also kind of going through and seeing what you can do to really help support your patients in the repair aspect of your 5R approach. So lastly, in our 5Rs, we have rebalance. So this is going to be discussed a little bit more later in the global dysbiosis talk. But I find that patients with IBD often maintain themselves in this fight or flight state, right? They are in sympathetic overdrive. They're always like this. They're always being chased by the tiger, and you got to figure a way to calm them down. So you need to balance out their sympathetic, parasympathetic, and support that parasympathetic. Like IBD patients are worried about life, they're worried about work, they're worried about where the bathroom is every day. So really trying to support them and finding ways to rebalance is very important. Although this is the last R and our 5 Rs, I find that I work on this from day one, and it's something that you need to continue to work on with your patients over time, no matter whether they have Crohn's or UC. This is very important in addition to everything else we talked about. Unfortunately, there's not a lot of published data looking at these kind of like mind-body approaches with IBD, but we do know that stress is a known IBD trigger for patients that have quiescent disease. It worsens disease with those with a flare, and there's a lot of data out there looking at these kind of interventions for stress. So you kind of just put that together. So mindfulness and aromatherapy, these are just a few studies that were published. Again, limited data, but I don't really feel like we need the data in IBD patients to know that patients need this. So it's very important to focus on the base of the tree, being able to rebalance the patients with inflammatory bowel disease.
And interrupt.
And here he comes again.
Here I am. So a couple of questions, Dawn, about
not hard ones.
Not hard ones. No, that's not hard for you. Maybe hard for you. So this Jing Dai that I've never used. So tell, and you give a wonderful summation of the literature. What is your experience with it? Are you using it?
Yeah, so it's been out for over a year, but I personally have just started using it within the past 6 months. We have about 30 patients that have gone through our center. I'm actually getting ready to go through the data to see exactly how things are going. I'm checking their fecal calprotectin before and after because I really want to see if this is working or not. I do think it is a good option for patients with IBD. It is not cheap. Like most supplements are expensive, but this one seems to me more on the higher side. Again, I come from an academic medical center. I work in an insurance model. Patients that come to a functional medicine clinic are a little bit different in regards to what they will spend. For my patients, they don't want to spend anything. So, but those that, I've been using it in patients who don't want to escalate therapy and they're not super sick, patients who have escalated therapy, but they're not quite of the way there yet. And I really want to, maybe I'm 80% and I want to get that last 20% because it's very important for me to heal at the mucosal level because that's where we're going to be able to stop the downstream ramifications of IBD. So I think there's multiple ways to use it and I am very excited about it.
And so talking about a few other supplements, so you didn't talk, you gave some literature on omega-3s. What's your experience with using high dose? I think high dose, I'm thinking 3 to 6 grams of omega-3s. Do you test for that? Do you do omega index? Do you do high dose of omega-3s? How are you using that?
Again, because of where I work and my patient population, we don't do a lot of testing because it is expensive for them. And as we all know, insurances don't cover that. Mm-hmm. I do definitely try to support their omega index, and I do use supplements, but I've not found anything in my personal practice or in the literature by doing that will really affect their underlying inflammation. I think it's just one piece of the puzzle that I try to optimize in the patients.
I got you. And you did talk about LDN. I think many of us are familiar with LDN and used in various autoimmune diseases. And so your experience with it is, you talked about the literature.
Yeah, for me, my personal experience is kind of 50-50. It's actually, when I first started using it last year or 2 years ago, it was kind of brand new to me. So I was literally watching and reading all these webinars and they're like, it's going to work. And then I'm like, okay, great. And then I'm like, it's not working. So, I think it's 50-50 in my patient population. It could be that fact that I deal with patients that have moderate to severe disease, right? So their inflammatory burden is huge compared to someone who's got mild UC or mild Crohn's. So I think it may be more beneficial in patients that have a lower inflammatory burden versus those who have fistulizing perianal, stricturing disease. But it's low risk. It's not that expensive. If it works, great. And if it doesn't, I didn't lose anything.
Mm-hmm. Yeah, and I want to reinforce this. Some people, in 2 weeks is it going to work? But you said 3 months. 3 months is the minimum, and that's what I've found as well.
And what I have read and Like it's a very sweet spot, like where a patient needs to be. And so you don't know where that sweet spot's going to be. So if you dose escalate too fast, like you're going to miss it, right? And so it makes it a little bit tricky what dose you need to be in. Because again, just like everything else, like not one size fits all. So that's why I kind of start slow and then kind of titrate up slowly. Although sometimes I've heard people say they titrate up quickly, but in IBD patients, I go slowly because I don't want to miss that sweet spot. And those patients that do have other mood disorders, we will typically dose like a BID dosing because that's a little bit more beneficial than just dosing at night.
Yeah.
I found.
Yeah, my experience is it's certainly not a panacea. I don't have near the experience you have with IBD. I use it in mainly in autoimmune thyroiditis and some other autoimmune conditions, but I found that in some people it really seems to help. They want to stay on it, and some people after 3 or 4 months, I don't push that after.
Yeah, I think they know, right? Like they'll know, like after that 3 months, they're like, I feel better, like I want to stay on it. So I think for a moderate to severe IBD patient, it's just another tool that we can use because there's again not one thing that works 100%. But if you have a mild to moderate patient, you may get away with just using LDN with all the functional medicine changes. But you just have to continue to monitor them and make sure.
Yep. I'll let you finish up and then I'll be back.
Okay, great. All right, so how about a little bit of Pearl? So IBD is complicated, right? Even for a general gastroenterologist, treating IBD is really confusing and complicated. And we know that the disease itself is driven by genetics, environment, microbial dysbiosis. So there is not one thing that patients need to do to make them feel better. I can't stress enough that you have to watch for the red flags in your patients. So perianal Crohn's disease, fistulizing Crohn's disease, upper GI tract Crohn's disease are all Crohn's phenotypes that need to be cared for in conjunction with an IBD specialist or a GI doctor that specializes or knows inflammatory bowel disease. These patients get very sick and they can die. I think it's also important to work with a gastroenterologist that supports the functional medicine model of whole body approach. And I think you'd be surprised out there, the newer generation of GIs definitely embraces this and they want the help. In the care of the patient, like one modality is often not enough to get a patient in remission. You can't just do one thing. Remember your 5 R's, but start simple, right? So again, no easy fix, and you got to make sure the patients understand that. You can't out-supplement a bad diet, and you can't test away a bad lifestyle, right? And so patients have to be willing to do the work, and it's our job to make sure that they understand that. So dietary strategies, there is a lot. I'm a big proponent of the elimination diet, and I'll show you in a second on how I use that. But you have to be mindful of fiber intake when working with these patients, especially those with stricturing Crohn's disease. So they have strictures, narrowing in their small bowel. By doing this and trying to increase patients' fiber, you can get into trouble and land some people in the hospital if you're not mindful about the fiber that they're eating and what they're eating. Definitely you want to optimize their vitamin status, so improving their micronutrients, their macronutrients, and their phytonutrients are all easy to do, and no one is helping them do this. So you definitely want to assess for that and monitor for that over time. I think it's also important for all patients, not just IBD patients, to remember your social determinants of health, which we've talked a little bit this weekend. We as functional medicine providers, I think I'm a little biased, we're a little better at listening to our patients than a traditional provider, but we need to understand their past to know where they need to go. Patients with IBD, it's a terrible disease. And so you need to be able to listen to the patient and, kind of create that rapport. And you need to be mindful of what they can and they cannot do. And the access to quality food may be an issue. And you need to understand everybody's barriers of care. So what did I do with the tools that I learned through IFM? So I started with the GI module and kind of worked my way through. So like Dan said, in 2018, I started the Vanderbilt IBD Functional Medicine Clinic. Just like everybody today, I think, feels, and even I still feel like it's so overwhelming. So I went to the modules. I'm like, I don't even know what to do. I don't even know where to start. And someone told me, like, if you don't know where to start, just start at the bottom of the tree. Just, you don't even need to know anything else. And then I was like, okay, great, that's what I'm going to do. I'm going to start at the bottom of the tree. And so everything that I learned in the programs over the past 2 years, I created a shared group visit program. And it was every 2 weeks for 10 weeks. And every 2 weeks, we met for an hour. We talked about the base of the pyramid. And we went through base of the tree. We went through all the different, sleep, stress, relationships, exercise and movement. We educated about that. During this 10-week time, we also did the 6-week elimination diet that you learned about too. And when we did that, and when I met with them, I tracked their patient-reported outcomes. And so in the medicine world, we call that your PROs, or your patient-reported outcomes. So I tracked that over time in patients that were coming through these shared group visits. So we looked at their FSS, which is their fatigue severity scale. We looked at their Pittsburgh Sleep Quality Index, which reflects their quality of sleep. We looked at their SIBDQ, which is their short inflammatory bowel disease questionnaire, which reflects their health-related quality of life. And then we also looked at that total MSQ, which is what we get in our toolkit, kind of looking at overall how you feel. And as you can see here, if you can't even see it, everything kind of trends that way. So over time, everyone got better, which was crazy because I didn't really know what to expect because nobody had ever done this before. So literally just by focusing on the base of the tree and going through a simple 6-food elimination diet, patients' fatigue, their sleep, their overall total symptoms, and their IBD symptoms literally improved in just 10 weeks. I recognize it was a very small cohort that I did. This was just 15 patients because this was just when I started. But after doing this for the past 2 years now, this continues to happen. So with just this, this simple intervention, like you think it's simple, but it's hard for them to do. This simple intervention, I was able to improve across the board. So most recently, this program has kind of evolved into a 12-week program because I kind of changed it over time. So after we did the 10-week program, patients really wanted to meet again to reintroduce and do that together. So now the program is 12 weeks. So it's we still do the 6-week elimination diet, and we focus on the base of the tree just in this specific shared group visit. Recently, I've been starting to check patients' fecal calprotectin before and after the 6-week elimination diet because I knew people were feeling better, right? So they were clinically improving. The patient-reported outcomes were getting better. But was I doing anything? Were they doing anything at their colonic level? So was the inflammation getting better? So this is just 3 patients because we were literally just started doing this. And we would check their fecal calprotectin before and after they did the 12-week program. And it's pretty impressive. So you can see case number 1. So this was a woman with Crohn's colitis. She was on a biologic, and I'd switched her to a different one, and she still wasn't any better. I scoped her, and she had moderate left-sided inflammation. She didn't really want to go on a different medication. She was willing to do the work, and she wanted to see how she did. And she's case number 1. So, fecal calprotectin is a stool study that's easily done. It's non-invasive. For a patient who doesn't have IBD, normal is typically less than 40. In an IBD patient, we want them less than 120 in a lot of cases. So a lot of times they won't get perfect, even though when they're in endoscopic remission. And so you can see the first woman before she started the program, her fecal cal was 413, and 12 weeks later it was 16, which is very low for an IBD patient. Number 2 is someone with ulcerative colitis, again, failed multiple medications. She felt better on tofacitinib, which is a JAK inhibitor, which is one of our oral small molecules, but she still had active inflammation. Not enough that I want to change her therapy because she felt better, but we were like, well, what can we do to see if we can get that endoscopic inflammation down? You can see before she started, she was 713, and after she was 137. The most impressive one so far was my 45-year-old patient with left-sided ulcerative colitis. She did not want to go escalate therapy beyond a 5-ASA, and she couldn't afford the 5-ASA, although I think it was going to work for her. She had mild to moderate rectal and sigmoid inflammation. Again, as you can see, all these patients are on traditional therapy, but they still have a little bit of mild to moderate inflammation. Before she started, her fecal count was 3,000, and in just 12 weeks, it was 11. So, I love a word cloud, so I got to finish up close to a word cloud. So, Crohn's, ulcerative colitis, is a lifelong debilitating disease. It is ruthless and relentless. It is awful. We did a lot of word clouds throughout the weekend, so I wanted to share a word cloud from IBD patients who attended one of our patient education conferences on what remission means to them. I think it's important for you to know as a provider that you are powerful and you can impact these IBD patients' everyday lives and really make a difference. So in general, use our functional medicine approaches. We want to keep calm and put out the fire. So we're going to finish up the last 20 minutes, 10 minutes or so talking about a case, specifically one of my patients. So this was a 19-year-old woman who started to have diarrhea after traveling to outside of the U.S., who got better with antidiarrheal medications. This often happens, right? This is probably her trigger, right? We talked about what is the trigger. So she went to Mexico. Maybe got an infection. So she left for college. She continued to have intermittent loose stools. When she went to providers, they just told her she was stressed or it was the foods that she was eating, which often happens in young women. Their symptoms get dismissed. After a year, she was losing weight. She was pale. Fatigue. She started to have joint pain in her hands and her low back, and then she started having blood in her stool, and she started having to wake up in the middle of the night to have a bowel movement. So that's one of our red flags when you talk to your patients, that this is not IBS. So IBS patients, again, can be debilitating, and they'll have maybe, they can have 10 stools to 20 stools a day, but once they go to sleep, they usually can sleep through the night. IBD patients can't sleep through the night. If they're going to the bathroom 10 times a day, they're going to the bathroom 10 times through the day at night. So once they go to sleep, that doesn't change. She doesn't smoke, but she started using NSAIDs pretty regularly for the joint pains and the headaches that she had. So in a conventional IBD care model, we did a colonoscopy. We saw that she had mild proctitis. So that means she has inflammation just in the bottom of her rectum. And you can see here in this picture, a very mild disease, kind of upper in the top part of the picture, that's normal. So you can see good vasculature markings. She doesn't have that erythematous kind of uniform and with those little kind of little white dots there. So we did blood work and stool studies. There was no signs of infection. She's got mild proctitis, so we recommended an oral or rectal 5-ASA from our topical therapy. As most young people do, and most people in general, they really don't like using rectal therapy or sticking things up their bottom. So she chose an oral 5-ASA, and she actually got worse. So she had more bleeding and stooling after starting the medication. When this happens, from a gastroenterologist perspective, we worry about 5-ASA intolerance. So anywhere between 3 to 12% of patients can have 5-ASA intolerance, where this medication actually makes them worse. So at that point, we offered her escalation to a biologic therapy or an S1P oral medication, which is one of our new oral molecules for ulcerative colitis. She didn't want to escalate therapy at the time, and she wanted to know what else could she do to try to help get into remission. So put on my functional medicine hats, using the go-to model, just like a traditional care, we went through and we made sure that all her labs were done, which I do anyway. You want to remember in patients with IBD, you always want to check their celiac serology. Celiac is sneaky, and a lot of patients can have celiac in addition to having inflammatory bowel disease. You want to know their systemic inflammatory markers. You want to check all their vitamin levels. In my IBD patients, B12, iron, vitamin D, I check every year. We made sure her stool studies were complete, so checking a fecal calprotectant, want to rule out infection. For her, we just did a C. diff and a GI pathogen panel because she's had been worked up with oral parasites for oral ova parasites in the past, so we didn't need to do that. When we really sat down and talked to her, going through our go-to-it model, she's only sleeping 5 to 6 hours a night. She was taking ibuprofen, which she admitted to weekly, I think probably more than that for joint pain, and we already learned that NSAIDs can be a trigger and can exacerbate inflammation. Due to her busy school schedule, she was eating frozen meals and ordering out often. She was drinking alcohol at parties on the weekends, really didn't drink any water, and she drank diet soda throughout the day. She couldn't remember the last time she exercised, and when you think about what she did in the past, she had recurrent UTIs, and she did have a history of taking antibiotics 2 to 3 times a year. When she was in high school, her parents got divorced right before she left for college, and then earlier she was C-section and bottle fed. So when we take all of this and we put it in our timeline, we see how everything lays out. So what did we do? So using our dig-in model, so her iron was low, her vitamin D was low at 18. She didn't have an infection. We know she has, increased intestinal permeability because she has ulcerative colitis. She has dysbiosis. Her CRP was elevated mildly because she has very limited disease, and her fecal calprotectin was elevated, unsurprisingly, because she did have active inflammation, and she has high stress in school. She's a teenage woman in college. So here again, just to remind you, she had mild inflammation, which we called, ulcer proctitis. So that just means inflammation just in the rectum. The rest of her colon was normal. Her terminal ileum was normal. So what did we do? We really just started simple. So going through our 5 R's, we want to remove those things that cause imbalance, right? So we replaced all her drinks with water. We stopped all of her artificial sugar drinks and food. She stopped eating fast food. She stopped eating processed food. We wanted to replace things that create support for what was missing in her diet. So she really wasn't eating anything. So we just started eating a fruit and a vegetable with each meal, like that simple. We started her on daily multivitamin, and we started her on vitamin D. And also for her, not on here, we also put her on a prescription vitamin D because her vitamin D was so low. So we want to replace those things. We wanted to optimize her lifestyle, optimize her vitamin status, optimize her phytonutrients, her micronutrients. She wasn't ready for an elimination diet yet. And a lot of times IBD patients aren't, so baby steps. From a repopulate standpoint, I did start her on a daily probiotic. From a repair standpoint, we worked on good foods and then also started her on a gut blend. And rebalance was really important for her because she, like a typical IBD patient, was just like this. So she was able to start working with a health coach. She's focused on sleeping 8 to 9 hours a night. Sleep is a huge trigger for IBD patients. A lot of times you'll find those that have active disease are not sleeping well. So again, working on their sleep is very important. She started walking 20 minutes every day. She journaled and she started, setting goals. So again, trying to modify her just over attitude toward life, improving her diet, promoting healthy living, all of that is rebalancing in her. So 6 to 8 week check-in, she's feeling a lot better. She's a little bit more excited about completing an elimination diet over the summer because she still is complaining of joint pain and fatigue, but she stopped taking the NSAIDs. In 6 months, we repeated her colonoscopy, which you can see here. And so this is now her rectum. And so this is what a normal rectum looks like. So good vasculature markings. She walks daily. She's got an exercise routine. All of her vitamin levels are at optimal numbers. And her systemic inflammatory markers, which I do recommend following, are all normal. So she improved with all these simple interventions, but I thought that there were certain foods that were driving her symptoms, especially about fatigue and joint pain. Again, fatigue is a huge problem, which I think we can do a lot from a functional medicine approach. When I talk to my patients, why do they need to do elimination diet? I talk about, identifying food triggers or intolerances, and we want to clear the body of those triggers. We want to support their microbiome. We want to reduce inflammation and increase their phytonutrient intake. I also tell them this isn't forever, right? Like this is a little bit of an experiment. So we're going to remove these things and then we're going to replace them and see what your body does. So it helps you try to figure out what you can do to help support yourself. So this summer, after a year of school, she did complete the 6-week elimination diet. I follow the same patient-reported outcomes that I talked about when we do the shared group visits. And here you can kind of see her PROs over time. So her fatigue score pretty much went down and half from the beginning till the end. And her SIBDQ score didn't really change, right? Because her GI symptoms were good because we healed her colon. Her rectum was normal. So we didn't really have a lot of movement in regards to that. You can see her sleep improved and her total MSQ score, again, a lot of improvement. So her joint pain and her fatigue improved by just doing, a 6-week elimination diet. So that's all I got. 10 minutes to spare.
You're right on time, Dawn. Go back to sit down and chat a bit. Well, thanks again, Don. So, there are, how do I want to start? Is that I just think that you have really shown us with with the functional medicine approach in an insurance model, and your connection with these patients. So it's always the combination of what that clinician is doing with that approach that there's some remarkable results in an academic setting. So I just want to compliment you on that. I think it's really remarkable.
Thanks.
I'd like you to just talk a little bit. You talked about the shared medical appointments and your studies a bit. Can you just tell us briefly about, I know it's growing, but about the clinic and how it operates?
Yeah, so I think I was a little bit of an advantage since I worked in a multidisciplinary IBD center. So I already had social workers, I already had dietitians that were part of the program. So this was just kind of like a natural evolution of what we were already doing, but just kind of like on a grander scale. I have buy-in and support from my institution, which I've always been very thankful for. I met my functional medicine PA at our IFM GI module, and so we just happened to be sitting next to each other, and we just happened to both be from Nashville. So I have a full-time PA who's certified in functional medicine that helps take care of.
I arranged that.
You did, yeah. You didn't even know me back then.
Exactly.
You didn't know I existed.
It was serendipitous.
Yeah, and so, I'm very thankful for that, though. But yeah, so she is certified in functional medicine. She does 100% functional medicine in our clinic. And so she runs most of our shared group visits through the programs that we've made. And I didn't talk about, we also have a nervous system regulation program. So for patients that aren't willing to do or can't do the diet part yet, really working on that mind-body calming aspect, we have visits for that. So the one good thing that COVID did, if I can say that it did anything good, is like it kind of pushed that insurance model to being able to pay for virtual visits. Just because before COVID, we could never do what we do now because insurances wouldn't pay for these telehealth visits. Once COVID hit, everything shifted. And so we were able to totally move our functional medicine model to virtual. So we were able to reach so many more patients because you do need to see them often, right? Yeah. And from where I work, most of our patients live anywhere from 1 to 4 hours away. So they can't come every 2 weeks for 6 weeks. But now that they can do it virtually, they literally can just pop on their computer at lunchtime. So we have a session at lunchtime. We have a session at 5. We have a special session in the summer for the teachers, who can't go during the year. So, and I also feel that these shared medical appointments, so when all these patients get together, like that is like a bonding experience for them. And that kind of heals them from a mind-body perspective because they see that they're not alone. So we have one practitioner and a dietitian sometimes also that comes on, and by working all together. And I did look at patients that just did this kind of work one-on-one versus the patients that did thing in a shared group model. The ones that did shared group did better. So I kind of try to push everybody towards that because I do think it's that group setting that really kind of like fuels the soul. And so it's like, well, if you can stop eating chocolate, I can stop eating chocolate. But if you're the only one in there, it's hard. It's not easy to do the elimination diet. But that's how we do it. We do shared group visits and you being able to use a telehealth model. And since she is a PA, so she is a physician's assistant, we are able to bill just like they're seeing her for a regular clinical visit.
Mm-hmm. And you have a dietitian or 2 dietitians and a social worker?
So we have 2 dietitians that kind of help support us. Since I'm lucky enough to have a provider who's certified, she can do a lot of the work. But if Like our patients want to do SCD, if they're having trouble with the elimination diet, if we need to do something a little bit more complicated, our dietitians are there to support that. We also have 2 social workers who are very kind of go beyond the social workers. So one of them certified in yoga nidra. They're both certified in heart math. So we do a lot of heart rate variability, and they're also getting started on getting trained in hypnosis. So really kind of supporting that parasympathetic is key, I think, for these patients.
Mm-hmm. And I believe you told me that you're in the process, or you're going to hire another nurse practitioner, and so you're expanding.
So we are maxed out. So we not only see patients from the IBD clinic now, but we also see patients from the nutrition clinic. We also see patients from the general GI clinic, and we just can't do any more. And so the university has been so supportive, and they've seen such great work we've done that we've able to hire, and we posted another job for a full-time provider. Plug there.
Absolutely.
And so that way our goal is to expand into other divisions at Vanderbilt. We want to go slowly, so I'm thinking probably endocrine and rheumatology might be our next stop.
Mm-hmm. And in terms of the shared medical appointments, you're doing this continuously, a couple of they're 12 weeks, but you're doing a couple of shared medical appointments a week, or your physician's assistant's doing that. Is that correct?
Yes, so she is. So she does multiple shared group medical appointments throughout the week at different time points. So then that way we have IBD ones, we have IBS ones, we have non-celiac ones. We have a small cohort of patients that have amyloidosis that we're working with. And so I'm hoping when we are able to branch out, like we'll be able to bring in some hypothyroid patients. So I like to group them in their disease states because I think it's easier for them to relate.
Yeah.
And then also it's a little bit different. So just like IBS and IBD is not the same thing, it's going to be really hard for you and I to be in the same group, understanding what I'm going through,
right.
Because I've got Crohn's and I'm kind of annoyed at you because you just have IBS. So I think it's important for them to have that, togetherness with other patients that are going through what they're going through, so they realize like they're not the only person. So we do these shared group visits, and then at the end of the shared group visits, if they're great, they just go on their merry way and they continue to work with their GI doctor or their other doctor. If they're not better at that point, or if they're not where they want to be, that's when we roll into the one-on-one model, and we go through everything that we've learned with the go-to-it and the 5 R's, and that's when we start introducing supplements or very specific things, because it does, working the base of the tree does work for a lot of patients with IBD, but not everyone. I find the ones that have more moderate to severe disease, or when they come into the program and they have active disease, like they need more. And so that's where we do our deep dives and get into our 5 R's.
Right.
And then I don't do a lot of testing. 1, because the patients can't afford it. 2, I feel like it's a waste of money in patients that have IBD. But once they get through the program and they go through the one-on-one and they're still not better and they're doing everything that they need to do, that's when we potentially will start testing for things, because there's something that we're missing and we need some more data.
Mm-hmm. That's a good model. And what I thought was really important that you said, either 40 or 50% of patients who go on these biologics, they just don't improve.
Yep.
And so it's a combination. It's a comprehensive approach.
Yeah, but biologics are great. Patients that need it, need to encourage them to start it. But again, it does not work in over less than half a patient. So, and even if it does work, sometimes it doesn't work 100%. Right. So what can we do? So that's why IBD is so complicated, right? Because we've got all of these little immune dysfunction and dysbiosis going on. And these biologics are great, right? They block anti-TNFs, they block IL-12/23, they block IL-23, they're anti-integrins, but that's not really the only thing that's driving our IBD. Our bodies are smart and they're sneaky, right? So if you block one road, then it just goes around the other road. And so by using functional medicine, we can kind of contain it all.
That's, and the last question for you before we break is, do you have... from a research perspective in IBD, in functional medicine, is there something that you're doing, that you're thinking about, a small group, or is there any research that you're thinking about moving forward with?
Yeah, so looking at the fecal calprotectin before and after interventions is something that I'm really trying to champion, and so that is a poster that's getting presented at ACG in Vancouver in a couple weeks. And so hopefully once we get more data on patients, being able to publish that and showing people like really you can change your microbiome, you can change inflammation with diet and lifestyle. And that's not something a lot of people understand. So, being able to empower patients to take that control back. A lot of IBD patients feel like things are happening to them, right? They have to take the infusion, they have to take the injection. So being able to show them that they have the power and leading them to that power is very important to me. Also, trying to figure out how do I take what I'm doing to allow another center to do that, or to allow another gastroenterology practice that doesn't have what I have. Like, how do we get them to be able to offer this to their patients? This is something that I'm passionate about and trying to think how to do that.
That's great. And I see we talked. I had one other question that.
No, time's out.
That you mentioned health coaches. I have a follow-up that you don't have to answer, but do you use health coaches in your practice, or do you incorporate them? Is that insurance?
So in an insurance model, the insurances won't reimburse health coaches. And where I am, you cannot pay fee for service. The way that I get around that is that we do have a health coach certification program at Vanderbilt. And so I use these health coaches that are getting their certification and meeting their hours. I connect them with my patients so they can get their hours with my patients.